Good morning, good afternoon, good evening. Thank you so much for joining this final session of ISUP's conference on applying theory to practice and trying to translate the evidence base into what we do in our work in drug demand reduction. I'm so pleased you're giving your time to join us. It's a very impressive panel of people that will be joining us to present. And I'll introduce our moderator, Christiana Sis from Indonesia. I want to thank you for joining us. I want to thank those that are presenting, particularly for the support from our national chapters that have been led by my colleague Livia Adega in terms of getting their involvement and support at all levels. We hope it'll be a productive and interesting afternoon. Just some points of housekeeping. To remind you that there will be a certificate of attendance that will be emailed to you after this event. So don't worry about that. There isn't that a certificate of attendance. The session will be recorded so that it is available on our website after the event. So it will be there for you to refer to if you miss anything out, and to recommend to colleagues who have not been able to join us. I think a very useful record, and hopefully will allow us to see this as a start of an ongoing dialogue of the issues that are raised. We hope we'll have time for a question and answer session at the end of our inputs. So please type any questions that you have into the question and chat section, which is on the panel on the platform for the GoWebinar. So any questions you have, please type into the answered question chat line on the webinar platform. And please bear in mind there is interpretation, and again the information on how to access the different languages is available on the chat section on the platform that you have in front of you. So we will try to make sure that the interpreters are able to pick up what's being said and translate it for you. I hope you have a very good afternoon, that it is of value. Thank you so much for those of you who are presenting. I'll hand over now to Christiana Sis, who will moderate this afternoon's session. Christiana is from ISUP Indonesia, and she will introduce the speakers and the afternoon session. Thank you, Christiana.
Okay, thank you, Jeff, and good morning, good afternoon, good evening to all colleagues in the world. And thank you, Jeff, for this opportunity. So today we have session 4 in the third day of ISUP Virtual International Conference. And in this session 4, we have the theme is Recovery, Evidence-Based Principle, Theory and Application. In session 4, we have 2 parts. And the first part, the topic is principle for evidence-based approach to recovery support. And we will have Dr. Henry Jones, PhD. And in the second part, the topic is identifying the need for recovery support in 3 countries. And we have an excellent 3 speakers in the second part. And for the first part, the topic is very simple of evidence-based approach to recovery support. And we have Dr. Henry Jones. He is Executive Director from UNC Horizon, and also she's Professor, Department of Obstetric and Gynecology, School of Medicine, and she's also the Professor from Department of Psychology, UNC Chapel Hill, and also Professor from Department of Psychiatry and Behavioral Sciences at Johns Hopkins University. And Dr. Jones is a licensed psychologist and internationally recognized expert in development, examination of both behavioral and pharmacologic treatment for pregnant women and children in risky life situations. And also, she has received continuous National Institute of Health funding since 1994 and has written more than 200 peer-reviewed publications. And she also has written multiple textbook chapters on the topic of pregnancy and addiction. And also Dr. Jones she's a consultant for the Colombo Plan, UN and WHO, and also member of NIH Hill Multidisciplinary Working Group. And she has won multiple awards, and most recently in 2020, Dr. Jones won the American Society of Addiction Medicine R. Brinkley Smither and Distinguished Scientist Award. So Dr. Henry Jones will present about evidence-based principle for working in recovery support, a consideration of the theory and science. So Dr. John, you have 25 minutes for presentation and the time is yours.
Thank you so much, Christina, for a beautiful introduction, and thank you to ISEP for this really important opportunity. It's an honor and a pleasure to be with all of you today, and I would like to share my screen with you so we can get started talking about recovery. And I think this is one of the most, oops, I'm sorry, that didn't work for some reason. Let me try again. Can you all see my screen? Hang on just a sec. It worked just fine.
Yes, we have seen your screen, Dr. Jones.
Do you see the slides now or only me?
No, yeah, your slide, and yeah.
Oh, perfect. You do see my slide.
Yes.
Okay, wonderful. Thank you so much. Because I was seeing me in a very large picture. I was like, oh no. So thank you so much for being here. And I would love for us to take just a moment to take a breath. Because so often, if we get up in the morning, we start our day, we've been in the mid-afternoon running around, or we're in the evening and have had a really full day, we often forget to breathe and to settle in and be present. So I invite you just for a moment to take a deep breath in, hold it, and let it out. And let's do that one more time. In, hold, and let it out. And that allows us the opportunity to really be present together today around the world as we talk about evidence-based substance use disorder recovery supports and what we know from the evidence. And so with that, I have a couple of objectives. So first, we're going to start from the basics of what is a substance disorder. So when we talk about recovery, we have to talk about what came before recovery, which is that substance use disorder. We will identify some differences between how recovery differs from treatment. We'll summarize the principles of recovery, look at just a few of the evidence-based findings that we have, and then end with talking about some research and policy opportunities. And so when we talk about substance use disorders, there was a sea change that happened, at least for the Diagnostic and Statistical Manual 5, where we went from abuse and dependence to a continuum of substance use disorders. And when we think about what is a substance use disorder, it really falls into mostly behaviors, as you can see in the red, the purple, and the green boxes. Those are all behaviors, our risky use of using in spite of putting ourselves in dangerous situations like drinking alcohol and getting behind a car, or continuing to maybe smoke cocaine even though we have lung problems. Impaired control is those incredible urges and cravings that people have, or saying that, you know, I tried so hard to cut down, or I'm only going to drink this one drink and I end up drinking 10. So that impaired control are behaviors that are so important to defining a substance use disorder. And then there's the social impairment. So all of the patients that I work with have broken promises and vows to themselves, aren't able to function, to go to school, to be the parents they want to be, to keep a job because of that social impairment. Their substance use gets in their way of their functioning. And finally, we have the pharmacological indicators, which are really the only two kind of physiological things. Are tolerance, meaning that if you take a substance and then the next time you take it, you need more of the substance to get the same effect. That's tolerance. And withdrawal is immediately stopping that substance, and you get the opposite effect of the drugs. And so like with opiates slow everything down. And then when you no longer have that, you get a sort of the opposite of sorts of bodily fluids and things start coming out of your body. And so I think that's really important, because so much of what a substance use disorder is behavior. And so when we see those behaviors expressed, rather than getting frustrated with people, what we need to remember is those are the expressions of the illness that someone has. And so rather than rejecting them and terminating them from treatment, let's see new ways that we can work together to embrace the person and help get their behavior under control and in new patterns. And when we do that, we are able to help people get into recovery. And so I invite you at this time, and I'm sorry we don't have the chat function, otherwise we'd have a super interactive conversation, but I invite you just to think for yourself, how do you define recovery? If you'd like to put it in the chat, we are going to be collecting that to see what your thoughts are and hopefully inform the future. But so take a moment to think about how you define recovery. Here is how the Substance Abuse and Mental Health Services Administration in the United States defines recovery for us, which is a process change, right? So it's a process. It's not a destination. It's a process of change. And it changes health. It changes wellness. It's in living a self-directed, autonomous life, and then striving to reach your full potential. So recovery is not just about not using drugs, right? That's an essential piece, but it's not sufficient for a recovery. And it's more than just, I graduated from treatment, right? It is a long-term process. It is a journey that is lived and practiced every day, and how we approach life and work through life without using those substances or using substances in a harmful life detrimental way. And so what is the difference between treatment and recovery? I can't tell you how many patients I have that have been in treatment and said, I'm fully in recovery because I'm not using drugs. And so we'll have a conversation, or I'm in recovery because I'm in treatment. Well, the thing that's distinct between treatment and recovery is treatment is a set of services that focus on initiating and keeping or maintaining that person's drug-free state or harm reduction, like not using substances or making their life better, understanding the role that substances are playing in their life. And so when we think about recovery and what evidence base we have for it, I love these pictures from the National Institute of Drug Abuse, where they actually show pictures of example brains from a healthy control person, where you can see there's lots of red that's going on, which is lots of activity of dopamine receptors. And then you can see with abstinence, with a drug-free state, you get a recovery of functioning, but it takes time. We can see that with methamphetamine. We can see that with cocaine addiction. So with time, brains return to a more normalized function with more dopamine activity. And so how do we help people get there? And there have been a number of recovery principles that have been shared for years. And for the sake of this presentation, I just created an acronym of HOPE CARES. Holistic. So a principle of recovery is it's holistic. It deals with the whole person. There's no one right way for recovery to occur. It's so individualistic, and it can occur from many different paths. Only you. It is person driven. We can't put anybody into recovery. We can't keep anybody into recovery. It is essentially their responsibility. And the E, it emerges from hope. Everybody that I know that is in sustained long-term recovery has an optimism about them, has gratitude for life, finds awe in little things and little experiences, and has a hope, expression and excitement for the future. For the CARES part, it's culturally based, so we need to think, well, we have these principles, they get expressed in different ways, depending on what community you live in, what community you're from, who you're interacting with. We need to also address trauma, those physical, sexual, and emotional harms that have come to many people who have an active addiction. We need to also involve the individual as well as those around them, their family members, and really build on the strengths of community. Where can we find helpers to help support people to put the structures in place to keep them in recovery? Respect, right? And that respect is respect for self and respect for others as we move through life. And then finally, the S, the cares part, is support, right? So we need, as many people have said, the opposite of addiction is connection. So recovery is so essential about a connection. There's been work that has been done looking at recovery dimensions. So not just the abstinence of drugs, but where is our physical and mental health? Where is our wellness in these domains? In terms of the home, that environment, the external environment that we're living in, what does that look like? And our home environment, how organized are we? I will never forget going to an adolescent treatment program in Brazil, and the young man showed me his closet. His closet was spotless, neat, and orderly. And he said, this closet represents my recovery. I know that when I can keep my closet organized, I'm doing well. When I start not doing that, that's a red flag that I'm going to have a return to use. So that's an example of environment. There's our community, which is so essential, right? If we have an NA or an AA or smart recovery community, as well as those non-substance using friends and families. Having hobbies, being engaged in alternative reinforcers that compete with drug use. And then finally, purpose, that personal growth, that personal journey that we're all on. Perhaps a higher power is something that's really essential and important to people in their recovery. And then why do you get up in the morning beyond yourself, beyond just using drugs or not using drugs? But what is that higher purpose, that higher growth mindset that is important for you? So to prepare for this presentation, I looked just in PubMed, which is, one of those repositories of scientific research, and pulled this. And so the first recovery article using the keyword recovery and substance use disorders or addiction, we could see is published in 1975. And I know that there's a long history of recovery movement well before that, but just in the peer-reviewed published literature, 1975 was the first one that came up. And in 2019, there were like over 200 articles that were published on recovery. So you can see that it's a rapidly growing and evolving literature, which is really exciting because so often we've looked at the problem and not looked at wellness and the solution and living a whole life and defining that and what are the active ingredients so that we can create a whole community, society, and world that has the opportunity to live up to their full potential. So what's the process of recovery? So these are just some more examples of key findings in the literature. We know that recovery, if you talk to people, it's highly personalized. Even though there's these principles that many people will go through and live and experience, it's still an incredibly personal journey. And one of the characterizations of it is this kind of growth, this like commitment to continuing to grow and evolve and want wellness and health, both in mental health as well as physical health. And we've also learned that that process of recovery can be really helped or impeded by those social determinants of health, all of those other things, the environment, the sort of the microenvironment, the larger structural socio-political environment can either support or hinder how someone recovers. And then when we think about individual responsibility, as I said before, no one can do recovery for you. That is your personal opportunity, responsibility, and you're always in the driver's seat. So it's important that what we know from different literature and writings is that action is essential. We can talk about recovery all day long, but until we actually start making those actions and doing what needs to be done to get well and stay well, it's just talk. And what are those essential actions for recovery? Self-acceptance has been widely talked about in the community, in both the research community and other writing community. Taking a personal inventory, where are our values and how are our values aligned with the behaviors that we are doing? And where they're misaligned, how can we harmonize our behaviors and our values? And then there's that important issue of self-control and learning self-control, emotional regulation, mindfulness are some key skills that have been very helpful to people for maintaining and getting into recovery and maintaining recovery. There's also been literature looking at the quality and the quantity of recovery. And so thinking about what are those indicators, how do we know personally and then as a research field and as a treatment field, how people are getting into recovery and staying into recovery. And we know that that supports need to be flexible, that oftentimes getting into recovery is not a linear process, it is undulating. And so how do we learn from mistakes or changes in behavior, put different supports around, internal supports, external supports, to help people achieve the life that they want to live. And we also know that that active part of recovery, if you don't practice it, it's not going to happen. And putting the recovery first. What are my essential values for how I want to live life, and how am I going to do that? And practicing it every day with a structure, no matter how long people have been in recovery, it is still a process, a journey, not a destination. There's also been research and literature talking about recovery capital. And so I would invite you, how do you define recovery capital? And if you have a moment, if you could put into the chat box how you define recovery capital, that would be great. And we'd love to be able to read your responses later and give some feedback. Here is how a number of the giants in the field, including Mr. White, have defined recovery capital. And so if you see here, the rainbow wheel of different aspects of life. And we know that there's both a breadth and a depth of both internal resources and external resources that we can use to create recovery capital and build recovery capital. And we know that when we have that recovery capital, all of those strong qualities and experiences, then there's an upward spiral. We're better able to cope with stress. Because what I often tell the patients that I serve is that, you know what, we can't control what happens to us, but we are always in control of how we respond to what happens to us. And it's that response that I think is such an important part of recovery. And the more recovery capital we have, the more strengths we have, the better able we are to cope with those stressors and manage those stressors and prevent those stressors. And so the wheel here is just a wonderful little tool that we have been using. And you can put different, we actually work with patients to put different labels on this, whatever is important for them in terms of recovery capital. And you can see their numbers. So 1 is like very low recovery capital, 10 is the most recovery capital. And so asking them, how do you feel about the different labels that they put on the wheel here? And you'll see often there's kind of an undulating pattern, an up and down pattern of how they're doing. And this can be a really good recovery check-in. And then it also gives people an opportunity to say, hey, I'm feeling really great about area finance, but I'm feeling less good about my attitude. My attitude's been kind of bad this week. And so then you can have a conversation, either a self-conversation, doing this as a self-exercise, or doing it with like a peer support specialist or a case manager or even a therapist to figure out what needs to change to make your number go up and to live the life that you want to live of your full potential. And as we think about recovery, I think it's also critically important that we think about language, right? So what are those words that we use? Because words have incredible power for how we communicate and interact in the world. And words also have the ability to heal people. They also have the ability to continue to traumatize, discriminate, and harm people. And so I invite you to think about the language that we use, and also recognizing that it depends on the context where the language is used. For example, in AA or NA communities, it might be very comfortable and empowering for people to talk about being an addict in long-term recovery. When they go to maybe a physician's office, there might be a different language that is used, a more person-first language, a more medicalized language to represent the biopsychosocial illness of a substance use disorder or an addiction. Another language that we talk a lot about, at least in many of the programs that I work with, is the idea of clean or dirty urines. And that, by and large, is a very stigmatizing and discriminatory set of terms. And so thinking about if we were to talk to somebody about their HIV blood test, it would be highly unusual for the doctor to say, your blood test came back dirty for HIV today. It would be more appropriate and more recognized to say that your blood test came back positive for HIV. And so I invite you to think about how could that maybe work with the people that you're working with. To say, you know what, your urine or your biological sample is positive for a substance or negative for a substance. I've been drug negative for many years. So just think about how that might work for you. And then where do we put recovery in the overall system? So there's so much emphasis on treatment, and that is an essential part, right? It's a really, really important part. But now it's time to also turn our attention to a recovery-oriented system of care. What are all of those micro and macro level partners that we need to create a safety net, a wellness net, so that we're good at getting people well, getting them through treatment, and also keeping them well. And since we don't have cures for addiction, we have treatments. Treatments work while there's a set of services that continue to be in place. And so that those recovery services are really essential for helping to keep people well. And as you can see on the graph here, there are a couple of examples of ways that we can keep people well. And I just want to highlight recovery checkups. So making sure that you're regularly checking in with the people that you serve, regardless of their status in recovery. Having a yearly checkup with a doctor or some type of medical provider to see how they're doing. And then if there is a return to use, how do we quickly address that? Where can people go to not feel shamed and stigmatized? But let's take a look at what's happened. Let's take a look at your change in behavior and what can we do to get you back on track. And so just to kind of wrap up here, with the last few minutes that I have, I want to give some examples or ideas for policymakers about how you can embrace recovery. So we have a dire need to really educate the public on what is a substance use disorder and how people recover. And also understand the difference from treatment so that people, when they go in or they bring their family members to treatment, don't have unrealistic expectations about what that treatment's going to provide. And those family members and the public can understand what they need to do, what we need to do to help create an environment to keep people in recovery. Policymakers have a wonderful opportunity to really think about the role of empathy rather than stigma and discrimination, as well as personal responsibility in the recovery process. You can promote the benefits of recovery, thinking about public safety as well as public health. So recovery through those lenses can be a really helpful opportunity to think about those structures and supports. Let's help support those health departments in getting certification for recovery support professionals. We have a growing workforce, an exciting workforce that needs certification, credentialing, and a living wage to provide these life-saving services. And then making sure we're putting our money where our priorities are. If our priorities are on wellness and the support and health and well-being of our population, then our entire population, then we need more supportive care approaches and how we fund that. In terms of research, there's so many different exciting questions that can be asked about recovery. And I feel like, we've kind of passed the tipping point now and it's going to continue to explode. Really being able to study in an even more systematic way that long-term process of recovery. What are the best predictors of recovery so that we have those tools when someone comes in, we can better match people to treatment, to recovery support. To be able to better evaluate that whole process of recovery and thinking about not a one-size-fits-all, but what are the unique aspects in different populations that have different clinical needs, like women, and other individuals. And then thinking about how can technology play a role? We know that there are certainly recovery apps out there, but how do those apps, how effective are those apps, and how can we use and leverage technology to keep people truly connected when they can't be face-to-face with someone? I think there's huge opportunity to look at the economic and cost benefit of keeping people in recovery and recovery-oriented systems of care. And then it would be great to see clinical trials that actually compare recovery outcomes of individuals and communities with those that have or are living in a recovery-oriented system of care versus those who are not, so that we can really see those outcomes, get those cost data for the future. And then when we think about practitioners and program directors, oh, please help us educate both the families as well as policymakers. You have the opportunity to be an important educator in your community so that we stop blaming patients when they have bad outcomes. We need to educate on the personal responsibility of recovery and also ensure that treatment programs don't just stop, but they are connecting people actively with those recovery supports in the area. And if there aren't recovery supports, they're going to create their own. And with that, and then finally, we need to hire credentialed recovery support professionals. And so I'm going to end with a very short autobiography by Portia Nelson. Chapter 1, I walk down the street. There's a deep hole in the sidewalk and I fall in. I'm lost, I'm helpless. It isn't my fault. It takes me forever to find a way out. Chapter 2, I walk down the same street. There's a deep hole in the sidewalk. I pretend I don't see it. I fall in again. I can't believe I'm in the same place, but it isn't my fault. It still takes a long time to get out. Chapter 3, I walk down the same street. There's a deep hole in the sidewalk. I see it. I fall in. It's a habit. My eyes are open. I know where I am. It's my fault. And I get out immediately. Chapter 4, I walk down the same street. There's a deep hole in the sidewalk and I walk around it. In chapter 5, I walk down another street. And that is what recovery is. Walking down that other street and helping everybody walk down that other street. Thank you so much for your time and attention.
So thank you so much. Thank you so much, Dr. Jones, for a very wonderful presentation. So we know that recovery is not the same with treatment, and I think participants have many questions about it. And you mentioned that it needs holistic collaboration to support a very good recovery. So thank you, Dr. Jones, and we wait for the question from participants. And we will continue for the second part about identifying the need for recovery support in 3 countries. And the first speaker is Dr. Olha Milsakisva. I hope I can spell your name right, Dr. Olha. And Dr. Olha will present about a case study for recovery support in 3 countries. So Dr. Olha is psychiatrist currently working in the Lviv Regional Psychiatric Hospital and also as a teaching assistant at the Department of Psychiatric and Psychotherapy at the Lviv National Medical University. And Dr. Olha participates in international and local training as an integral part of continuous professional education, as it provides an opportunity to discuss matter with academic experts and professionals. And in 2014, Dr. Olha was selected for the ATTC project and started the course of educational training that served to deepen her knowledge in the field of addiction and drug demand reduction. And currently, she conducts training, supervision, and help to improve the motivational interviewing skill among specialists who work with people using substance. And also since February 2019, she has been the national trainer and supervisor of MHGAP-IG, and also she is ISAP National Coordinator, Asian Region. So Dr. Olha, you have 15 minutes to present and the time is yours.
Thank you, Dr. Sista, for your great introduction. It is my pleasure to be here with all of you today. And I hope you can see my presentation. So Release recovery support is now being identified as a specific area of our response to substance use disorder, as identified by the previous speaker. Trying to find examples of practice are often difficult, as it is a relatively new area for specific considerations. In 3 countries, I will refer to ISAP national chapters in Ukraine, Pakistan, and Kazakhstan, have taken the initial step to address provision and needs for this important issue. And my input will summarize the outcomes of this research and offer recommendation for action as they move forward to address recovery support. Recovery support services are one of the key components in continuing care of substance use disorders. In many countries, recovery support interventions are not available at the state healthcare facilities, and most of them are focused on the treatment of subjects with substance use disorders. The response in many countries to those with a substance use disorder reveals some responses of long-term isolation, involuntary treatment, and even imprisonment. And at the beginning of 2021, ISAP Pakistan, ISAP Kazakhstan, and ISAP Ukraine supported an initiative and conducted a joint research identifying family needs and availabilities of services that provide care to family members of the subjects that were using psychoactive substances in these countries. We realized that in many countries, treatment and recovery interventions are mostly focused on the subject with substance use disorder without any intervention with the family. Nevertheless, the role of the family and family members is often critical. They can create a supportive environment and play a protective role in the recovery process. Alternatively, they can trigger worsening of the condition and even provoke a relapse. So results showed a great need for recovery programs for families and their broad implementation. And today, on behalf of ISAP Pakistan, ISAP Ukraine, and Kazakhstan, we'll present the case studies that will be focused on the importance of research to evaluate needs assessment in the country, providing new data and planning further steps and development. The objective of our study was to identify the involvement of families in the treatment recovery process of the subjects using substances and to provide data from the region to identify examples of good practice and then disseminate this information. We gathered quantitative and narrative data, qualitative data from the 2 online surveys created based on the Universal Treatment Curriculum 14. The first one was completed by the family member of subjects who use substances, survey 2 by subject who use psychoactive substances or with a diagnosed substance use disorder. So in total, we have collected 1,098 responses for survey 1 in 3 countries. The survey was completed, I'll tell once more, by family members of the subject with substances. We received difference of responders' gender between the countries, and in Ukraine and Kazakhstan, survey 1 was mostly filled by females with no significant difference. In Pakistan, the association between the family members' type of relationship and its characteristic was studied, and the following results were received about strong emotional involvement, warm and supportive relationship, mostly reported biological parents in different countries. It's 66% or 730 replies from 3 countries. Analysis of results received from each of the countries revealed that most of the responders in these 3 countries identified their role with protection of subject from the negative consequences of their substance use and taken on responsibilities and achievement-oriented goals. 47% of the family members didn't receive treatment or any intervention, and in this group, they considered substance as family, mostly in Kazakhstan and Ukraine, as society community problem, mostly in Pakistan, and individual problem. It's mostly in Kazakhstan. In Kazakhstan, Ukraine, and Pakistan, 77% family members agreed that substance use negatively impact on them. 55% responders reported that functioning of the family worsens, and totally 87% believe that treatment can be an effective option to stop using substances. Next slide. Family members were asked what is the best way to treat substance use disorders, and in all three countries, most of them replied that the best way was to isolate person using substances in the healthcare facility. Totally 69% responders from three countries. It's 66% in Kazakhstan, 31% in Ukraine, and 31% in Pakistan. 77% in Kazakhstan, 84% in Pakistan, and 76% in Ukraine feel shame, feeling of guilt, regret, or sadness because a family member use substances. And these results can be associated with stigma and negative attitudes to subjects with substance use disorders. And we suggest that this is an interesting topic for another research in these countries. The biggest challenges that family members are facing with respect to members who use substances are fear about substance use and relapse and inability to trust. We have received total of 1,075 replies for survey 2 from subjects who use or have used psychoactive substances, and majority of subjects in Pakistan, Kazakhstan, and Ukraine have agreed that substance use negatively impacts them and their family unit, worsens family functioning, and that treatment can be an effective option to stop using psychoactive substances in the future. Only 19% of subjects in Ukraine and Kazakhstan have disagreed with these statements. And similarly to family members, 77% of subjects in Kazakhstan, 81% in Pakistan, and 63% in Ukraine feel shame, had feeling of guilt, regret, or sadness that they use or have used substances. And most of subjects in Ukraine have received treatment interventions such as medical treatment, 40%, and 60% of the subjects in Pakistan didn't receive any treatment intervention. In Kazakhstan, it was 34% of subjects have received medical treatment, and 33% didn't receive any treatment intervention. So each of the national chapters also analyzed and sent information about healthcare system in their country, treatment protocols, and family counseling. In Kazakhstan, treatment and recovery subjects with substance use disorder is carried out in accordance with the clinical diagnostic and treatment protocols. There is no approved program for working with family members, and it is not included in the treatment protocol. The involvement of family members in the process of treatment and recovery of drug-addicted subjects is not so widespread through the Kazakhstan. Groups with family members are working on the necessity, on the demand request from codependents, and also there is a law in the country that compulsory medical measurements can be applied to persons with a mental disorder associated with the use of psychoactive substances by a court decision. In Pakistan, patients suffering from substance use dependence are treated in different facilities. Most of the treatment and rehabilitation is provided by private psychiatric hospitals and drug treatment centers. And treatment used to treat addiction in Pakistan are biological, psychological, spiritual, and herbal. Existing services are unable to cope with the estimated 4 and 25 million dependent users in the country, and only some government and private institutions offer family therapy along with rehabilitation of drug addicts. According to the assessment of addiction treatment services in Ukraine, individual counseling in state and non-state facilities prevails over other type of counseling. And family counseling is underrepresented in facilities that provide treatment and recovery for people with substance use disorder. Very often such counseling is offered by 19% of state addiction treatment clinics and 6% non-state addiction treatment clinics, and 43% of state institutions never offer family counseling. Addiction treatment in Ukraine is presented by a variety of services, mainly biologically oriented models of care in state institutions. And the quality of care is often not satisfactory and doesn't cover the existing treatment needs. Family plays a very important role in prevention, treatment, and recovery of substance use disorders, and usually treatment protocols are focused on treatment of the individual family member and not the whole family, who may play a protective role in a recovery process or become a factor provoking relapse. And it is very important to work with families to inform them about the evidence-based practices on treatment, recovery of substance use disorder, on communication strategies, provide them psychological support. And based on the results of our study, our working group considers the next steps and action points that would be divided for different levels. At the national level, we consider the following next steps: to improve national standards and protocols for addiction treatment and recovery that include a family-based approach and recommend family intervention in comprehensive addiction treatment. Conflicting documents and standards on confidentiality that influence family involvement must be agreed. We may think on the system of monitoring of addiction treatment and recovery services, including family involvement levels, and on special incentives for addiction treatment and recovery programs that use family-oriented interventions. Include patients and family association into policy development and service planning. Besides, it is very important to implement in the university curriculum education programs on family intervention in substance use treatment and recovery, and training programs for specialists in substance use and family therapy. And to continue data collection, conducting research to evaluate the efficacy of this implementation, to study the family needs of people with substance use disorders and effectiveness of family involvement in the addiction treatment and recovery programs. And to continue this work on community level, encouraging the development of community programs for families of people with addiction and raising awareness among the community about the role of family and family programs in substance use prevention, treatment, and recovery. And I would like to thank you for your attention, and a huge thank you for the representatives from ISAP Ukraine, ISAP Pakistan, and ISAP Kazakhstan for their great team job and commitment to the developments. Thanks for their work. We will hopefully publish results of this research in the Addictology Journal next year. Thank you.
So thank you, Olha, for the very nice presentation. I think it's very important research that assess about family intervention to support recovery. As Dr. Jones mentioned, is family involvement is very important to for recovery for the people with substance use disorder. Thank you, Dr. Olha. And the second. Yeah, thank you so much. And we will wait for the question from the participants. And the second speaker is Dr. Beatrice Kathunga will present about a case study for recovery support in Kenya. Dr. Beatrice is from ISAP Kenya, and she is a full-time faculty member in the Department of Psychology at Kenyatta University, Kenya. And she already published many publication and won research grants and presented in numerous conferences. And also she is a member of ISAP Kenya Executive Board and also the Global Master Trainer with Colombo Plan. And she is the current coordinator of the International Consortium of University on Drug Demand Reduction African region. So Dr. Beatrice, you have 15 minutes to present and the time is yours.
Thank you very much. for that introduction, Christiana. I hope you can see my screen and I hope you can hear me.
Yes, we can see your screen and hear you very clear.
Thank you very much. So good morning and good afternoon and good evening to everybody. I am very happy to get this opportunity to participate in this great conference and thank ISAP for the initiative and thank all the participants that have logged in and my colleague presenters for the great presentations that I already have witnessed. I wish to share my experience trying to build a recovery-oriented system of care in a setting that is a university while reflecting on what is evidence-based. I want to say that in addition to the little biography that has been presented, I also do two things in my university that help me to think of this presentation or to reflect on the ideas in this presentation. First is that I am the director in charge of accommodation services in the university. We have about 10,000 students that I take care of on a day-to-day basis who are hosted in the hostels and the accommodation in the university, besides the rest that are outside the university. Secondly, I am a member of the Alcohol and Drug Abuse Prevention Committee of the university, and therefore, a lot of what I'm going to be sharing in this presentation then is seen from that or from those two eyes that I have. So what is it that we are as a university? I just want to say that universities are institutions of higher learning that have populations that are diverse in very many ways, in terms of age, in terms of socioeconomic status, you know, ethnicity, religion, nationality, gender, and every other thing. In terms of developmental stage, we do know that many of the students that are in the university are in their late adolescence and early adulthood. Now, Kenyatta University is a large public university. It is actually the second largest in Kenya, and it is located in the capital city, right in the heart of Nairobi, with over 50,000 students, over 3,000 staff, over 10 different schools and many campuses with different backgrounds of students, both local and international. Now, as a university, we are keen on student support, and therefore we have an elaborate structure that strives to help the university achieve its core mandate of research, academic achievement, as well as community outreach. And therefore, you will notice that we have a rich network of student support services in form of directorates, in form of sections, in form of sectors. And so these are some of the support services we have in our university. We have the university health services. We have the wellness and rehabilitation services that takes care of a lot of the issues of substance use disorders. We have a student affairs section. We have a career development and mentoring. We have the accommodation services that I head. We have catering services, security, gender equity and empowerment services. We also have chaplaincy that supports students. We have sports and games and many more, and these are just examples. Now, we note that our students use a lot of these support systems, and they may enter the support system from any of the entry points that I have just described. And also, referral does take place from each of these sections to the other. Now, in terms of the context of substance use in universities, we note that universities are a high-risk context for substance use for many reasons. First and foremost is that they are exposed to the external factors where we have increased availability of drugs in the community. And so we realize that our university does not exist in a vacuum. It exists in the bigger community. So the more there is increase in availability of drugs in the community, the more access then it has to the students in the university. And students are generally targeted as rich catchment area by suppliers and traffickers. We have actually noticed that when our first year students report to university, the tendency for them to get lured into beginning to use substances is very high because they are seen as a rich catchment, you know, for drugs. They also have resources coming from family, coming from friends, and also some of the students are working. At the same time, we notice that once students come to the university, there is increased freedom that they didn't have when they were in high school. There is more space for them to make individual decisions. There is a lot of cultural diversity. So they may be introduced to values that they didn't have, their value systems are tested, and because of this, many of them easily get swayed into beginning to use substances. There is also less monitoring by parents and staff, where you find that they are desiring to discover their own individuality away from the family, and therefore many of them actually get tempted to experiment with drugs. We have increased social relationships, including intimate relationships. And sometimes some of these relationships act as a risk factor for drug use. I do remember we have had some occasions where we have some students, female students, that say that they have begun abusing cannabis because their boyfriend introduced them to cannabis and threatened to leave them if they did not use. So we have seen quite a bit of that. So we're saying there's a lot of risk within universities. And therefore, just like the rest of the community, universities will encounter cases of students using substances, students suffering from effects of substances. And of course, the other interesting thing about universities is that the staff coexist with students in the same environment. The client and the service provider are in the same environment. But I have chosen to focus more on students. Now, what is the impact of this substance use exposure? We have many experiencing health challenges, whether physical or mental. We have got negative impact on academic work, where you find some students will consistently perform poorly, others will delay in completion, where you find the student is supposed to take 4 years to complete a program. They are still struggling with the program 6 years down the line. When you interrogate, you discover there is an element of drug use right in there. Others drop out altogether. We also have, cases of conflicts with fellow students. And we have discovered many of these conflicts, especially in their hostel areas, have a lot to do with the student had abused a substance, so they came and they were violent and aggressive. And so that is a common, occurrence when we have substance use. Some may actually get into conflict with the law, especially those using illegal drugs like cannabis, which is illegal in our country. Others will actually engage in, thefts of fellow students' items as a way of trying to get, access to resources to sustain their drug use. Of course, many of them will have strained family relationships. We have had cases of students that have been expelled from their homes and they are actually homeless. And so when they are in the university, it is probably their only home. When it's time to close, it becomes quite a challenge. So those are some of the impacts. Now, as a university, what is it that we are doing? We are responsive and we are making efforts to do something. And the university has invested in structures such as programs to address matters of substance use among the university community, both students and staff, along a continuum of services. And our response ranges from prevention to treatment, all the way to ongoing care and recovery support. Now, some of these things that are happening include policy interventions. We have worked hard to develop an elaborate alcohol and drug abuse policy that was just approved last year as a way of trying to transform what we have been doing from fragmented activities to a consolidated set of activities in form of a policy. Now, this policy addresses issues of prevention, it addresses issues of support for treatment, as well as rehabilitation and support for ongoing recovery. We already have a committee in place to guide the university. It's called the Alcohol and Drug Abuse Committee. Now, one of the things that this committee does is that it was, at the forefront of pushing for the development of the policy and the approval of the policy, and is now working hard towards disseminating that policy. We also do prevention and advocacy, where we target diverse groups, both students and staff. We have programs that span across, the whole continuum of prevention services. We engage in universal prevention services, where we look at the entire university population. We also think about selective programs, where we look at risk, population. For example, our incoming first-year students or freshmen, we take time to look at them as a high-risk group, and therefore we target them in prevention programs. We also have indicated programs where we focus those who are already having problems that require much more support and a connection to treatment. The other thing we do is to try and identify and reduce risk factors. For example, we try and figure out what are some of the things that could be making some people more vulnerable. How can we address some of these factors? And we try to build protective factors as a way of supporting prevention. We also use enforcement, where we try to engage in efforts to minimize supply of alcohol and drugs. We have got our security directorate and other related sections. Right in the accommodation spaces, we have security staff that work towards ensuring that they are enforcing the issue of abstinence from substances, which is part of our policy. So this involves control mechanisms. We have compliance with the relevant standards. We have got surveillance of areas that have been identified as hotspots, and we also collaborate with the local external administration because our students also interact with the local environment around them. Now, in terms of capacity building, we have got efforts that have been made towards providing education on evidence-based practice, in areas of prevention, in areas of treatment, in areas of recovery support. These activities are coordinated by the Directorate of Wellness and Rehabilitation, which is one of the Student Support Services Directorate that I mentioned and which I also sit in as a board member. Now, in terms of research, we have tried to make efforts to do some research. For example, we have tried to look at prevalence of alcohol and drug abuse among staff. We are still yet to do a good study among students. We have tried to look at risk and protective factors, also looked at a bit of impact, as well as some of the strategies that we can use for intervention. Now, in terms of support for treatment and rehabilitation, one of the things that we do is to identify students and staff that need rehabilitation. Now, we do not have a structured way of doing this as yet, but currently they are referred from different sections of the university. And when they are referred, then we take them to the Wellness Directorate. We may refer them to the University Health Services. We may also connect some to external service providers, and some may actually refer themselves. Now, in the other policy, we have anchored some of these aspects to try and standardize the approach, but we are yet to disseminate it sufficiently for us to have a structured way of doing it. Now, in terms of our achievements, we do have a clear and elaborate policy in place, like I said. We do have active prevention programs. We even have a week that we call Drug Awareness Week, especially when the freshmen arrive. We have several capacity building sessions that are held by the Directorate of Wellness Services that target diverse sections of the university. And some of these sections include the accommodation staff section, as a way of ensuring that the staff that are within hostels and accommodation of students have some level of capacity to know what to do when they discover a student is affected by alcohol and drug abuse. We do have some baseline data, and we also do support sometimes some students and staff for treatment. We also have strong partnerships and collaborations. Now, who are some of the partners we have collaborated with? We have an organization that is called NACADA, the National Authority for the Campaign Against Alcohol and Drug Abuse. It is actually our focal point for matters alcohol and drug abuse in Kenya. So it's our key partner. We use NACADA to help us or to support us in terms of dissemination of information, sensitization, and it also helps in terms of regulating activities of prevention within a national level. And therefore, we have got targets that have been set by government that NACADA supports us in terms of implementation. We also have an organization called Basic Needs, Basic Rights, which tries to promote mental health, including issues of response to alcohol and drug abuse. We have got ISAP, Kenya and the Global, that supports us in terms of access to materials and resources that we can use for capacity building. We also have treatment centers. Some are government, some are private, that partner with us. We refer staff to them. We refer some of our students to them. Some have been very kind to us to even give a little, support or scholarship or sponsorship to some of our students who are very needy. We also have a mental health champions program that we partner with to build capacity of our staff. This has happened especially to our staff in accommodation, so that they are more equipped to be able to recognize when students are needing support. We also have some non-governmental organizations like Pathfinders that also support other activities that are related to risk reduction for substance use. Now, what are the lessons we have learned over time? First is the importance of generating evidence so that we can be able to understand the magnitude of problem and the nature of the problem we have. Secondly, we've also seen the value in capacity building, people that are in critical areas. Now, these critical areas include the student support areas like accommodation, areas like catering, areas like student affairs, among others. We also have learned the value of stakeholder engagement, and particularly engaging with top management, so that whatever we are doing has got the blessing and some sort of resource support from management. We also have learned the importance of partnerships and collaborations. We still have some challenges and gaps actually in terms of capacity and expertise, particularly to implement evidence-based practices. We're still quite a mile behind. In terms of dissemination of our policy, we are still trying to figure it out, and that is still a challenge we have. Of course, constraints of resources, of finance and time, because we do not see prevention and treatment and recovery support as a core business of the university. We have got issues of access to treatment and rehabilitation, where you have really needy students and really needy staff, but they can't access treatment because of resource capacity, because where we want to give them admission in government spaces, the COVID-19 impact has reduced capacity. So all these are challenges. We also have a big challenge where we tend to focus on acute care model, as opposed to a long-term recovery support, as we have seen from the presentation from Dr. Jones. Sometimes we find that the identification of students and staff at risk of severe SUD comes in very late. So by the time we are identifying them, they are really in acute care needs. And so we really do not have a way of early identification and action. We also have increased co-occurring disorders, where many of the students that are using substances are also affected by co-occurring, especially medical and mental disorders. We have depression, we have schizophrenia, we have got conditions like HIV, we have got tuberculosis. We have seen a lot of this co-occurrence. We also have a weak case management system, whereby we find that our support services are fragmented. So we do not have a standard way of referral across the continuum of care to ensure, for example, that if a student is identified in accommodation, referred to wellness, referred to health services, referred to an external rehabilitation setting, they can now come back and get supported across the system. So we have a weak referral and weak follow-up, of course, also weak monitoring of recovery post-rehabilitation. And because of this, then we do witness quite a couple of relapses. We have also observed that there's a lot of social and self-stigma from the clients themselves, where you find the students who go, for example, for rehabilitation and they come back, they don't want to step out to get more support for fear of being stigmatized. We also have very weak family support for recovery, where you find sometimes students are actually abandoned by their families in the university. I have had myself as a director of accommodation had to do a lot of advocacy for students to their families, for students to admission centers, because families have actually abandoned. And of course, we have inadequate data to support the activities that we do. We are optimistic about opportunities that we still have to grow and to partner further. For example, we want to do more research for evidence generation, want to do more capacity building so that we are promoting evidence-based practice across the continuum of care. We want to build a recovery-oriented system of care so that we move more and more away from the acute care model to having a support system that recognizes that recovery is a long-term process and must integrate all the different service providers. We want to be able to do early identification and intervention, including screening and brief intervention. We want to build our capacity to address co-occurring disorders and do strong case management, including referral, including linkages, including screening, including assessment, and many other elements. We also want to enhance access to treatment and rehabilitation for needy students with severe substance use disorders. So we are seeking partnerships, we're seeking advocacy, both at the institutional level and even with national partners, as well as other stakeholders that can be able to help us to increase recovery support for our students. That is my presentation. I want to acknowledge three people here. I want to acknowledge our director in charge of Directorate of University Wellness and Rehabilitation, Dr. Tabitha Wangeri. I want to acknowledge the chairman of our University Alcohol and Drug Abuse Prevention Committee, Dr. Gabriel Wari. And I want to acknowledge our Vice Chancellor, Professor Paul K. Wainaina, for the great support they continue to offer towards trying to establish our university as a recovery-oriented system for our students. Thank you very much.
So thank you, Dr. Beatrice, for your very interesting presentation. And we know that university student is one risk population to use a substance like in Indonesia. And you mentioned a very interesting topic about the research, and we will discuss about it in question and answer. So thank you, Dr. Beatrice, for your presentation. And next, we move to the third presenter, Dr. Pamela Kaithuru. She will present about a case study for recovery support in Kenya. So Dr. Pamela Kaithuru is head of counseling unit, Kenya Meteorological Department, and she's also the ISAP Kenya Executive Board and credential as an addiction professional. And Dr. Pamela has widely published several papers in the field of addiction, HIV, and also climate change. And she is recognized trainer in the public sector with over 15 years of experience facilitating workshop and seminar in cross-cutting issues like HIV, alcohol and drug abuse, mental health, and gender mainstreaming. So Dr. Pamela Kaithuru, you have 15 minutes to present and the time is yours.
Thank you, Christina, for that introduction. I truly appreciate this opportunity to interact with the global community in issues recovery. I'm so excited to be here. I appreciate the fact that my fellow presenters have made a very good presentation, and I want to really just take us through a presentation, also a case study for Kenya. And as you have said, plenty, or as the community has been able to present, plenty has happened in terms of recovery, in terms of drug demand reduction. And even in Kenya, a lot is happening. And this is what I'm going to share briefly with the global community, so that then we can be able to see what is happening in other countries that can either be replicated or serve as evidence that can be used in other nations. I hope my presentation is being seen by us all. Can I get a confirmation? Hello?
Yes, we saw your slide presentation, Dr. Pamela.
Okay, thank you so much, Christina. Allow me to continue. In the next few minutes, I'll be looking at what is the vision, what supports our interventions in terms of support for recovery, especially at the workplace. What is the goal that drives that desire or activities that surround recovery? What are the actions that we take? And again, look at what is the success story. And I want to point out that globally, we know that interventions are guided by policy. As it is, even with the case of Kenya, we are members of the UN family, and we are guided by the Sustainable Development Goal, especially goal number 3, that is on good health and well-being for all. This is a global goal that, as the global community, part of, treatment, health is part of the global goal to ensure good health for the population. Knowing that the nation's population or the people drive growth. Therefore, if we have a healthy community, then we have ability to grow and prosper as nations of the world. From that, then as a country, Kenya, we have the Vision 2030 that has several goals to achieve, from which then we have the big 4 action points or agenda that His Excellency, the President of Kenya, has really emphasized and wants to achieve. And one of these 4 very critical goals is the goal on affordable health care for all, and including mental health. This is further cascaded down by ensuring that institutions develop policies that actually Sorry, I think is my presentation being seen? I think I've lost my presentation.
Yes, we saw your presentation, but it doesn't move, Dr. Pamela.
I don't know where I touch. I lost it. Can you see it now?
Yes, we can see. You can see the slide.
Okay. So then, as government and especially the public sector, we have policies that guide interventions. So the interventions in terms of drug demand reduction or substance use, it's actually guided by the public sector substance abuse workplace policy that guides all public agencies, that is the ministries, the departments, the parastatals, and even the counties. From this policy, it is able to provide a framework on what should be done, gives roles and responsibilities to various players to ensure that drug demand reduction occurs or substance use is prevented and managed well in workplaces. This is the document that guides the institution for which I work, the Kenya Meteorological Department, is guided by this substance abuse policy that is provided and usually, of course, reviewed as need occurs. So the institution for which I work, the Kenya Met Department, is the department that is mandated to provide accurate weather and climate information for all the sectors of the economy, especially now we know the whole world is faced with the issue of climate change. This is the department that provides information that is able to guide the country in terms of climate change. All the data, the weather and climate information is gathered by this great community of scientists, currently with a staff establishment of about 700 professionals that are able to do this work. So I'm going to use this department as to represent the entire public sector as a case of what is happening in terms of support for recovery in the workplace. So the goal of the interventions is actually to enhance individual and institutional productivity. We know what happens or how disabling or dysfunctional a human being becomes because of substance use disorders. So then, and knowing the driver, the employees are the drivers of the economy and the ones that are able to help us achieve the goals of the institutions. Therefore, enhancing the individual productivity will essentially enable the institution to achieve our mandate so that then we can spur socioeconomic growth for the nation, as well as trying to ensure that we reduce the disease burden, knowing that the health sector is very key in terms of driving development. We find that a healthy population will be able to ensure that we achieve our Vision 2030 as a country, that institutions achieve. Therefore, by the interventions that we do at workplaces, we are trying to reduce the disease burden for the country as well as enhance personal growth. The workplace becomes an entry point to help the individuals grow, as well as, by extension, the ripple effect being to the community as well, and therefore being able to help our nation move forward. Currently, as it is in the country, statistics indicate that we have a big challenge, more so as a country, in terms of alcohol abuse, tobacco, amira, all these substances of abuse are a challenge, according to our agency that coordinates issues to do with drug abuse in the country, the NACANDA, the statistics they give us for 2021 really indicate there is a need for interventions. And this is in the general population, which then means the workplace is also affected. Having this information also helps the workplaces conduct their baseline surveys to be able to establish as a workplace, where are we in terms of substance abuse? What are the commonly abused substances in our workplaces? So that then we can be able to drive interventions at the workplace. So therefore, the problem really is that the workplaces in Kenya are having a challenge, and more so the public sector workplace, for which I am sharing this experience, for which I work as well, that alcohol use disorders have the highest prevalence, and the severity is increasing, and therefore means that we need to really put a lot of effort in place with this information, so that then we can be able to reduce substance use disorders even in workplaces, and also prevent the same. So what are the actions that we take in workplaces? As I said, we have a policy that guides us. And with this workplace policy, therefore, the ministries have the responsibility to sign performance contracts that includes indicators on substance use prevention. So with the indicator for the top management of the government agency to be able to prevent alcohol and drug use in the workplace, therefore, a committee is formed, for which I also belong in my ministry and in my institution. I belong to this committee that is charged with the responsibility to ensure that the institutions achieve the target of prevention of alcohol and drug abuse in the workplaces. So this gives us the mandate to create awareness, to inform the employees, to share information with the families of the employees, considering that they are the significant other of this employee of the government institution. We reach out to them with information. We also reach out to our stakeholders, those who interact with the workplace. We are able also to identify the needs. As awareness is being created, the supervisors, the managers are also informed on what to look out for. The individual employees are also empowered on what to look out for, so that we can be able to identify the needs early enough, so that treatment and management can begin. Then we have a counseling unit which offers counseling. The government employed counselors in the public sector, so that they can be able to support all employees of the government. The counselors are professionals that are cut across the ministries or the institutions, so that they are able to offer counseling, so that they are able to assess the staff, and therefore create the necessary referrals with the networks that are available, with the institutions that the government works with. I need to bring out here that the national insurance provides for support for people with substance use disorders. This then means, as workplaces, when individuals are identified to have needs, they are supported by the health insurance. They don't struggle on their own to treat, knowing that treatment and recovery is a process, and as well as very costly. Therefore, government has put in place mechanisms to ensure that staff who are struggling or who are recovering from substance use are also supported. We work with rehabilitation centers, so that then we refer these clients and as well monitor them during the treatment even after discharge, so that we know that they are getting to get the necessary support. We keep tabs with them even as they work, and even with the families, so that we can be able to give them the support, the correct environment for recovery. As we have learned, recovery is very, very key. So as a workplace, we have a responsibility, knowing the value of these staff, knowing the value that they bring to the institution, therefore to be able to look out on them so that we can even support them to manage the emerging issues that would hinder their recovery. As I said, the immediate family members of the staff are also covered by the same insurance, such that as a member of staff, my spouse, my children who are under age 20 are covered by the insurance. Therefore, if I have an issue or a staff member has an issue with the family, they are also taken care of by the same process. So we also endeavor to create awareness among the family members and even the workforce, so that then we can have an environment that is conducive for treatment. We know there are triggers, and at times the society or the people that the person in recovery interacts with could trigger the interactions at the family level, at the workplace level, could trigger one not to be able to manage their treatment or recovery well. Therefore, we create awareness around the family, with the family and the workplace, so that then we can be able to support recovery, as well as ensure that as evidences emerge on management of substance use disorders, then our policies are either revised or inclusions are made, so that then we can be able to improve recovery and also management as a workplace. As I said, it is seen as an entry point to the community as well as to the country. What are the achievements so far in the public sector? According to the NACANDA, the standard they did in 2021, this year, evidence is there that at the workplaces, and especially the public sector workplaces, awareness is there about the existence of the policy, which then means once people are aware what is provided, then they are able to seek support. In terms of mainstreaming, that ensures that all the as people work, they have in their mind issues to do with how to prevent substance use disorders. Policymakers, budgeting, and other programs at the workplaces are able to integrate substance use management at the workplace. In terms of sensitization, 30% as it is are sensitized at the workplace. Messages are veiled in all forms, that we have posters, we have brochures. Now with ICT, the country having embraced ICT, especially in public sector, we use WhatsApp, we use the emails to pass messages to the staff, and organizations that have documents that are sent to staff, there is a message that keeps reminding people about issues to do with substance use.
So, Dr. Pamela, I'm sorry, because of the limitation of time, can you jump to the conclusion of your presentation?
Okay. What are the issues, the challenges? We have our people are shift workers. So being a risk factor, there are non-communicable diseases that are comorbid. Then we have family dysfunctions that is a society issue, and changes that occur continuously. Again, we have few professionals that are available. Stigma related to substance use disorders is there. And of course, funds can never be enough. So this is a challenge. And as I conclude, I need to say that government has realized an employee is the greatest resource that we can have, Therefore, interventions are put in place to ensure that our employees are taken care of as we try to reduce drug demand in the workplace as a ripple effect also to the community. Thank you for your time. I appreciate it.
Yeah, so thank you so much, Dr. Pamela, for your wonderful presentation. You mentioned a very important workplace as the port of the entry to enhance the recovery, to involve the family and also the environmental to support the recovery. So thank you, Dr. Pamela, and I invite all the speakers to turn on the webcam because there are several questions for the speaker. And the first question is for Dr. Jones. The audience asks you when the 4 dimensions are not supportive for individual recovery, what do you recommend about it? Dr. John, please.
Yes, thank you so much for the opportunity to answer that question. So to rephrase the question to make sure that I understood it, it is basically, what do we do if we have individuals who might be struggling with one of those important dimensions that we know help support a recovery journey? And so I think one of the places where you can start is actually the recovery wheel that I showed in that slide. You know, the most important thing we can do for someone is have a conversation with them, an authentic conversation, and really listen to them and be with them. And so talking about the discrepancy between reality, so what are those pieces in that one domain that, what do you want it to look like? What does it look like now? And then what are those things in the person's control that we could do to help them get there? And what are the things that are external to the person? Maybe you as a peer support specialist or as a case manager, or a therapist, or recovery coach can do to help link them to a new resource or a new support in some way to help make steps. And sometimes we make very tiny steps. But I think continuing to have those conversations about where you want to be and where you are now, and then what we can do to create some goals, to create some process to help people get there, can be one way of helping to strengthen one of those domains that might not be as strong as we want it to be. Thank you.
Thank you, Dr. Jones. And there is another question about recovery. The question is, how about the roles of a rehabilitation center in the recovery process? Where does the role begin and end?
Oh, yes, what a wonderful question. And I think that, you know, it can really vary depending on the community and circumstances and resources. So I think having good relationships and good communication with treatment partners so that recovery centers can be part of that important fabric, or even the kind of navigators to different services. If there is a return to youth, then that recovery center needs to know where to send people, who to communicate with, who to collaborate with. You know, is there a need for a hospital? Is there a need for a detox? Is there a need for an outpatient treatment? Or can some more less formal supports be put in place to help get the person back on track? And, you know, again, it depends on, we want to accompany people within the limits and the boundaries that we have. So making sure that our workforce working in those recovery centers are credentialed, are supported, are earning a living wage, and have good supervision in a clinical supervision way can all be really important supports for the workforce to be able to best determine where that relationship begins and ends with the person they are serving. Thank you.
Thank you, Dr. Jones, for the explanation. And we will move to the other question to Dr. Beatrice. You mentioned about self-stigma in your presentation. And please, could you discuss self-stigma and how to address it? Please, Dr. Beatrice.
Thank you, Christiana, and thank you for that question. Indeed, it's a very interesting concept because sometimes our recovering clients, students, and staff will refuse to go to attend a support system, a support group, because they think that people are seeing them as dirty, as not fit, as not able to manage themselves, and they are adults. And so even when our wellness directorate tries to establish a support group, then you find that the people that are supposed to benefit don't present themselves. So we're actually even wondering whether we're going to make it a mandatory process of attending the support system, because then if they are not attending the support system because they are afraid of what people are thinking about them, that becomes a challenge. The other thing that we're trying to do is invite the counselors to come to the specific departments. So in my department, I have about 150 staff under me. So sometimes I want to invite the counselor to come and I give them a safe space within the work setting to come and have a conversation with them, rather than them look like they are going to the wellness center and they are thinking that going to the wellness center is an indication that something is wrong with them. So we're trying to navigate, to think about creative ways to address that. Thank you.
Yeah, so it's very effective method then. Thank you, Dr. Beatrice. And the question is for Dr. Olha. So Dr. Olha, you mentioned that around 84% family feel ashamed because of the a member of the family using drugs. And then how to involve them to involve in the treatment process or the recovery process, because maybe they will deny about the situation of the member of the family. Please, Dr. Olha.
Thank you very much, Christiana, for this important question. And the recovery support services means a broad range of non-clinical services. And these services usually assist individuals and also families. And the role of families is very important in stabilization and maintaining long-term recovery from substance use disorders. Can you repeat once more what was just?
Yeah, how to involve the family into the recovery process because they feel ashamed of it.
Yeah, it's very important to involve families and to work with families, the same as working with subject. And as I mentioned in my presentation, most of the intervention are only focused on subject. In many countries, and all the protocols doesn't include any intervention, how to work with families. In many countries, there is no trainers that could train professionals how to do it properly. That is why we decided to raise this question, because many countries only treat the subject and that's it, and even doesn't provide often recovery process for the subject. And we would like to work now on this continuum of care, and families are really important. It's very important to link family to all these processes. Thank you.
Yeah, yes, and in your presentation, you also mentioned about how to make a special program to involve the family in the treatment process. So thank you, Dr. Olha. And the last question for Dr. Pamela, you mentioned about workplace, and it is very important of port the entry to do intervention. And in your experience, how effective is it to involve workplace to prevent substance use, or to have the effective treatment to involve the family also?
Thank you, Christina, and thank you for that question. The family is very key in recovery. At the beginning, once a staff is identified with a need, then as a unit, we reach out to the family so that we can involve them in ensuring that the staff goes for treatment. We link them to the rehabilitation or the treatment facility and follow up to ensure that the family goes for the family therapy, because the treatment centers have family therapy twice per month. So we follow up with the family members because we know how significant they are in treatment. More so, also we try to educate them so that we can reduce stigma even at the family level, knowing that the chronic nature of the conditions that are related to substance use disorders, we know there is likelihood of going back to it. So we empower the family also so that they can be able to understand these identified patients, so that then they support them. And by supporting them, they help the workplace for this person to be able to produce better, as well as we also reach out to the community around the workplace. So that helps us to pass the information and support the country in the interventions.
Mm-hmm. Yes, thank you, Dr. Pamela. So to end this session, I would like to enhance about how important for us to develop the comprehensive recovery support model. And then it's very important to involve the family, the community, and then we can start from doing the research. And by doing the research, we can educate the community how effective is the model and how the outcome of the model, and the public will believe about the model. So I think it's very wonderful session. Thank you, Dr. Jones, Dr. Olha, Dr. Beatrice, and Dr. Pamela for the wonderful presentation. And I will give it back to Joanna.
Thank you very much. Thank you, Christiana, for moderating the session for us, and thank you to all of our speakers. I am just here to hand over now to Livia Edegger, our Deputy Director, who is just going to make some final comments for us. Thank you, Livia.
Thank you very much, Joanna. And on behalf of ISEP, I would like to thank today's presenters and also the presenters from our other 3 sessions. And I also would like to thank our moderators and especially our national chapter representatives for their help and invaluable input. We had excellent moderators from ISEP UAE, ISEP Nigeria, ISEP Chile, and ISEP Indonesia today. We have seen phenomenal case studies from our national chapters in Kenya, in Mexico, India, Peru, Lebanon, Ukraine, Kazakhstan, and Pakistan. I feel like we have learned so much in the past 3 days, and we leave this conference with new insights, with new learnings that can inform our work in the field. And we really appreciate and are very grateful for the expert speakers, for your contributions, for sharing your knowledge and the wealth of information and practical examples with us. I am excited to share that the conference was very well received. We have received many congratulations wishes, positive feedback. There was a lot of engagement and vivid and lively discussions. We had around 700 participants from over 140 countries and territories around the world. And so thank you all so much for joining us from all the different regions in the world. And shukran lakum, spasiba, muchas gracias, and merci beaucoup to all those of you who connected on our Arabic, Russian, Spanish, and French language channels. And thank you to our interpreters for their great work. I would like to particularly thank the ISEP team under the leadership of Joanna Travis-Roberts, whose birthday is today, so happy birthday, Joanna, from all of us. I would like to thank my colleagues for their dedication, for their hard work in organizing this event. Special thanks go to Jeff Lee, our senior consultant, for offering his expertise in planning and implementing the program and bringing the exceptional group of speakers together. The conference would have not been possible without Jeff's vision and his endless commitment to our field. I would also like to thank Diana Crossan, our events manager, for her support in the conference planning. I would like to thank James Harvey for communicating and marketing our event. And also, at last but not least, I would like to thank ICEP's very own webinar support specialist, Olivia Woodrow, for whose technical expertise and endless patience and problem-solving skills make conferences like this one possible and a great success. For those of you who would like to rewatch the conference session, like we said at the beginning of each session, we will share it on our website and on our YouTube channel. You will also be sent an email afterwards with a certificate of attendance in the coming days. We wish we could spend more time together following up on these interesting discussions and experiences, knowledges, and I encourage you to please use our online tools, our networks, our knowledge share to connect with professionals in your country and around the world. And we would also like to invite you to join us next May at our conference in Abu Dhabi. Please keep an eye out on our website and communication channels, to receive updates on the conference program and on the registration details. And also, I would like to invite you to get involved with your national chapter in your country. So thank you all, stay safe, and we're sending you greetings, seasonal greetings to all of you. Thank you.
Thank you, Livia. So now we will hear our closing comments from Melody Heaps, who is chair of ICEP. Thank you, Melody.
Thank you. I am totally pleased to be here today and to thank all of the ICEP team for the work that they have done in putting this together. It does take a village to do this. I also want to thank the leadership of the national chapters and representatives, and of course, all of the presenters. On behalf of the board, good morning, good afternoon, good evening. I mostly want to thank you, the members of ICEP. It is an awe-inspiring thing to understand that no matter how many miles separate us or how much our cultures and histories are different, that in fact we are united as a family, a global family, committed to the mission of preventing and healing substance use disorders. And I am so greatly glad, and I know all of us are, to be a part of the family. It's not enough, however, to have passion and compassion in this healing process. What is necessary is that we have the tools and the practices based on science to make sure our mission is a success. And to that end, ICEP is your organization. ICEP is here to support you, to provide the knowledge, the information, the education as to the latest practices and science-based tools that you work. Please use the ICEP website and ICEP to continue to learn, to grow in your knowledge, to increase your expertise. In addition, please use the ICEP website for mutual support and dialogue. It is important that we remember that we are a family and that we are dedicated to one mission. And it is rather remarkable that we can use technology to support each other. And I am so grateful for ICEP to have developed the kinds of connections on our website. And when I see that so many of the members are talking to each other, I'm very, very excited. Please understand that the ICEP board and the ICEP team have such admiration and gratitude for the work you do to provide that healing touch to individuals, families, and communities. I wish those of you who celebrate during this season happy holidays, and mostly I wish each and every one of you a very safe and very healthy new year. With that, keep up your wonderful work, and may the blessings of our higher power be with us always. Thank you.
Thank you, Melody. So it is the only thing that is left is for me to say thank you, echo everybody's thanks to all of you for joining today. If you are not already an ICEP member, please go to the website, join, it's free. There's a wealth of resources and we really look forward to welcoming you to the ICEP family. If you are an ICEP member, thank you. Your contributions are hugely valuable and we are very much looking forward to continuing these dialogues, the relationship building and networking with you all. Have a restful rest of your day, whatever is left of it, whichever time zone you're on, and we look forward to seeing you at the next event. Thank you very much. Bye bye.